Well, now we need to take the next step, and that means looking at Medicare's acute care payment system. I want to raise the topic of site-neutral payment reforms. This is a policy MedPAC has highlighted for several years now. The President's most recent budget even included a site-neutral policy with respect to services provided in hospital outpatient departments. So this area of payment reform is not, or at least should not be, a new or contentious topic. This year's June report brings us new information and data that could help us elevate our discussion in this area. MedPAC has found that for some cases, we're paying as much as $4,000 more per case simply because there's a discrepancy regarding status. That is, was the patient supposed to be classified for inpatient status or outpatient status? Unfortunately, this is a real question the hospitals are faced with. But because the inpatient and the outpatient payment systems are so different, it's hard to get an accurate assessment of what's driving this trend. More to the point, the codes that are used to determine what Medicare should pay for inpatient services are entirely different from those used for outpatient services. Not only does this mean hospitals are responsible for managing two different billing systems, but it means Medicare has to do the same. And the issues with payment disparity become magnified when we consider that Medicare is expected to spend more than $130 billion on inpatient services and $40 billion more on outpatient services this year alone. Clearly, this is an area ripe for reform. MedPAC has proposed some innovative solutions. I look forward to hearing more today. Also, MedPAC's testimony focuses on indirect medical education and disproportionate share hospital payments, two add-on payments that certain hospitals receive to help offset the cost of teaching medical students or treating a larger volume of uninsured or underinsured patients. It's important to note that when we're talking about payment disparities between the inpatient and outpatient systems, that these two add-ons, IME and DISH, are only included on the inpatient side. Outpatient discharges aren't eligible to receive these payment adjustments. As a result, these important payments get caught up in a financial numbers game that end up driving incentives. I believe both of these programs are critical and need to be redesigned to deliver the most targeted payments possible, as arbitrary add-on payments are just not achieving their mission. As MedPAC notes in the June report, and as Medicare's own trustees tell us each year, the program is facing serious fiscal and demographic headwinds. Spending is out of control, and the current financial underpinnings will soon not be able to sustain the program for the long term. Congress needs to tackle these issues, and we need to tackle them now. We've already started down this path by successfully reforming how Medicare pays our local doctors. My hope is we can carry this progress over into other payment areas.